Hi, my name is Ann Graf-Ladisa, and this lecture will discuss the pharmacotherapy of hypertension and heart failure. So there are two main things that this lecture will aim to accomplish. First, we're going to review the current guidelines that exist for hypertension and heart failure. This will be a top-level review. So if you want more details on the clinical trial data, the levels of recommendations, and evidence basis, you can find that in the treatment guidelines. And I've included links to the guidelines in the online reading section of the overview page for Unit 2. So you can dig into those guidelines and review more details there. The other thing that this lecture will aim to accomplish is to just really discuss the classes of agents and drugs that are used to treat hypertension and heart failure. A lot of them are similar medications, and they're just used, have different rationale for use in each of the disease states. We'll talk about the pharmacology, we'll talk about monitoring for efficacy and safety of these agents, and any other notable aspects. I will assume that you are familiar with the pathophysiology of these disease states, so we will not review hypertension or heart failure in that capacity for this lecture. So as I mentioned, there are several evidence-based guidelines for these disease states. We have the 2014 evidence-based guideline for the management of high blood pressure in adults, and for heart failure, we have the 2010 Heart Failure Society of America Comprehensive Heart Failure Practice Guideline and the 2013 American Heart Association Guideline for the Management of Heart Failure. So as I mentioned, links to online copies of these guidelines are listed in your Unit 2 overview document under online readings, but they can also easily be found online with an internet search. So some of these documents are very long. So they're there for your reference and review. I don't expect you to read them word for word in their entirety, but they're there to help clarify and solidify concepts that are taught in this lecture regarding the drug therapy for these disease states. And then also, they're there for your overall reference for when you're caring for your patients in your practice, as well as for non-drug therapy aspects of the disease. Guidelines for the treatment of hypertension are referred to as JNC 8, and these were published online in December of 2013. And these guidelines are from a panel of members that were appointed to the 8th Joint National Committee. That's where JNC comes from. So these guidelines recommend evidence-based treatment thresholds, goals, and medications for hypertension management in adults. So this only applies to your patients that are 18 years old or older. The evidence is from randomized controlled trials, and the quality of evidence is graded. So you can, all those details are in the documents for your review. And really there's 5 key trials that informed many of the changes to the latest guidelines, and they refer to those trials throughout their rationale behind the recommendations in the document. They do point out that these recommendations are not a substitute for clinical judgment. So in your practice, you also must consider clinical characteristics and circumstances of the individual patients when you're making your drug therapy choices. So this slide reviews the blood pressure goals that the authors of JNC 8 have published. And in essence, if your patient is 60 years old or older and does not have diabetes or chronic kidney disease, the goal blood pressure is less than 150/90. So if your patient is 18 to 49 years of age without major comorbidities, so they're younger people, and older people who greater than 60 who have diabetes or chronic kidney disease or both conditions, the blood pressure goal is less than 140/90. So a couple of things to note. With regards to diastolic blood pressure in younger patients 30 to 59, studies showed that cardiovascular events, heart failure, and overall mortality was reduced when the only focus in the trials was a goal diastolic blood pressure less than 90. So they didn't consider the systolic blood pressure at all. And some experts in this panel that published JNC8 wanted to make diastolic blood pressure less than 90 the only goal for these younger patients, citing that there was insufficient evidence for the benefits of a systolic blood pressure less than 40 in patients that were less than 60. But the more conservative experts involved in the guidelines pushed to keep both a systolic and diastolic blood pressure target. So keep that in mind when you're treating these younger patients in your practice. Also, when to initiate drug therapy is when the blood pressure is above goal, and you're also going to want to institute lifestyle changes as well in combination with the drug therapy when blood pressure is above goal. And lifestyle changes include the DASH diet, weight loss or maintaining a healthy weight, decreasing sodium intake to less than 2.4 grams a day, at least 30 minutes of aerobic exercise most days of the week, smoking cessation, and limiting alcohol intake. So I think those things should all be familiar to you. I also wanted to point out one thing, that there is an exception to the goal blood pressure in one specific group of patients. And the guidelines suggest that patients that have chronic kidney disease or albuminuria that are 70 years old or older, so your very older patients, that they receive treatment based on their comorbidities, their frailty, other patient-specific factors. So there wasn't enough evidence to support a blood pressure goal of less than 140 over 90 in these patients that were older with chronic kidney disease or albuminuria, so age of 70 or older. So with these people, you might have to provide a little bit more individualized care as far as determining, do we really need to lower their blood pressure to less than 140 over 90, or can we go a little, or can we let it ride a little bit higher just based on the patient themselves? So the guidelines identify 4 classes of medications to be used as initial and later line drug therapy. The 4 classes of medications include thiazide-type diuretics, or thiazides, calcium channel blockers, angiotensin-converting enzyme inhibitors, or ACE inhibitors, and angiotensin receptor blockers, or ARBs. I should point out that there are other types of diuretics, so you should be able to differentiate between the different types of diuretics, and the guidelines specifically mention thiazide-type diuretics as one of these 4 classes of medications. In talking about later line alternatives, it's also from these 4 classes of medications that we use as a second or third agent. A lot of patients will need more than one blood pressure agent to get their blood pressure within goal. So when you're thinking of adding a second or a third line agent, you're choosing from these 4 classes, or the guidelines recommend that you choose also from one of these 4 classes of medication. From a pharmacist perspective, it's also, I think, taking 1 or 2 medications you'll have more compliance from your patients than if they're on more than that, or 3 medications. So I think it's helpful to try to max out the first drug that you put them on before adding a second medication, and then titrating that up appropriately to a max dose before adding a third agent. I think taking less than 3 medications will improve compliance, so you should consider that when you're thinking of adding. The guidelines also recommend that you do not use a combination of an ACE and an ARB together. However, you can use combinations of the other medications in this group of 4, just not the ACEs and the ARBs together. I also want to point out that the randomized controlled trials that that were reviewed for these guidelines had limited as far as representation from specific non-hypertensive populations. So even though antihypertensive are used to treat people with heart failure or coronary artery disease, those trials were not reviewed for these. So we're talking strictly about patients who have we're treating their hypertension and they don't necessarily have these other disease states. So when you're treating a patient with coronary artery disease or heart failure, you should apply these recommendations with caution when you're treating their hypertension. So this table has some examples of the medications in these classes, along with doses that you might see. It doesn't list all of the drugs in these classes, but you can use your drug reference databases to identify additional drugs in these classes. But these are common ones and ones that were reviewed in the randomized controlled trials that were reviewed for the guideline publication. The guideline authors also note that it's important to use it's important to dose the medications adequately in order to achieve the results that we're seeing in these randomized controlled trials. So which medications would be good initial drug therapy choices for our patients? Well, the authors note that there are some studies for which the results for Black people were different from the results for the general population. So in your patients that are non-Black, you can use, or the guidelines recommend, any one of the 4 drug classes as initial drug therapy. However, ACE inhibitors and ARBs may not be an ideal choice in your Black patients. So the results from a subgroup analysis in the antihypertensive and lipid-lowering treatment to prevent heart attack trial, or ALLHAT trial, found that ACE inhibitors led to worse cardiovascular outcomes than thiazide-type diuretics or calcium channel blockers in patients. Now, the recommendation for using a thiazide or calcium channel blocker for Black patients with diabetes is weaker than the recommendation for the general Black population, because outcomes for the comparison between the initial use of a calcium channel blocker compared to the initial use of an ACE inhibitor in Black people with diabetes was not reported in any of the studies that were eligible for the evidence review for these guidelines. So they had to use extrapolated evidence from the ALLHAT trial to come up with this recommendation. And 46% of those patients had diabetes. So just not as strong of evidence for the recommendation of using thiazide, diuretics, or calcium channel blockers in your Black patients with diabetes. So despite the subgroup analysis of the ALLHAT, the results of the African American Study of Kidney Disease and Hypertension, or ASK trial, supported the use of first-line or add-on ACE inhibitors to improve kidney-related outcomes in patients with African descent with hypertension, chronic kidney disease, and proteinuria. So as a result, the JNC guideline authors recommended that all patients with chronic kidney disease and hypertension, regardless of their ethnic background, should receive treatment with an ACE or an ARB to protect kidney function as either initial therapy or add-on therapy. So also in patients with impaired renal function that are greater than 75 years old, ACEs and ARBs may be beneficial, but the evidence is lacking, and use of an ACE or an ARB may increase potassium, serum creatinine, or promote further renal impairment. So those agents might actually need to be discontinued for safety reasons. So for this reason, in this group of patients, a thiazide or calcium channel blocker is also an option. You do need to be cautious with the degree of renal dysfunction in using a thiazide diuretic, though, for efficacy reasons. We'll talk more about that when we talk about thiazide diuretics in particular. The guideline authors also make recommendations for monitoring your patients. They say that if your blood pressure goal is not reached within 1 month, then it's time to either increase the initial drug to the max dose, or if the increase is not tolerated, add a second agent from one of the 4 classes based on your patient characteristics. And then again, as a reminder, do not use the ACE inhibitor or an ARB together. And again, from a pharmacist perspective, I really would recommend that you try to titrate up that initial drug before adding on a second drug. If the patient tolerates it, then it would be advantageous to not have them on more than one agent. However, as I said, a lot of times people do need more than one agent, so just make sure that you're giving them a chance on the max dose to see if they can tolerate it before adding the second one. So if your blood pressure goal is still not achieved, then you can increase the second drug to max dose and then add a third agent from the 4 classes and titrate that to the max dose as well. They recommend that if the blood pressure goal has not been achieved with 3 drugs, or you can't use 3 drugs because maybe one of the classes is contraindicated or the patient doesn't tolerate that, then you should refer the patient to a hypertension specialist. Okay, so let's talk about these 4 drug classes a little bit more in depth. Thiazide-type diuretics decrease blood pressure by decreasing blood volume, by inhibiting sodium transport, predominantly in the distal convoluted tubule. They block the sodium and chlorine transporter, and they enhance calcium reabsorption in the distal tubule. Now, despite this, they rarely cause hypercalcemia in your patients. So things to monitor with thiazide-type diuretics: of course, blood pressure response, because you always want to monitor for safety and efficacy. You're going to monitor electrolytes as well. You're going to look at potassium and sodium. And then also your serum creatinine. These drugs tend to lose optimal efficacy when patients have an estimated creatinine clearance less than 30. So as I pointed out in our patients with the chronic kidney disease and proteinuria that are older in the last slide, or in 2 slides ago, and they recommend calcium channel blockers or thiazide-type diuretics. You're just gonna want to be cautious because if the creatinine clearance is less than 30, might not be. These drugs might not be effective. You should also point out to your patients that a high salt diet negates the effects of the drug because of the mechanism of action. So patients should be, if they're following their lifestyle recommendations, limiting sodium intake to less than 2.4 grams a day. But also patients on thiazide-type diuretics should avoid using large amounts of NSAIDs as they can retain sodium as well. NSAIDs are nonsteroidal anti-inflammatory drugs that are used for treatment of pain, like ibuprofen, naproxen, things like that, which we'll talk about in later units. Angiotensin-converting enzyme inhibitors, as the name implies, inhibit the enzyme that converts angiotensin 1 to angiotensin 2. So by doing this, it also prevents the inactivation of bradykinin, and the overall result of this is inhibition of vasoconstriction, so therefore it decreases blood pressure. ACE inhibitors specifically have benefits in diabetics and heart failure patients. So in diabetics, oftentimes ACE inhibitors, in addition to lowering blood pressure, help prevent kidney damage by slowing the progression of proteinuria. And then also in heart failure patients, It decreases, so even if your patient isn't hypertensive and has heart failure, the ACE inhibitors can decrease blood volume, which will slow cardiac remodeling and reduce preload and afterload, which is beneficial for these patients. So things to look for safety and efficacy in patients on ACE inhibitors are, of course, blood pressure response. And then also you want to make sure that you're monitoring potassium in these patients because ACE inhibitors can cause hyperkalemia. Specifically, be extra cautious in your patients that have pre-existing renal insufficiency, that use salt substitute because that's potassium, that also are on concomitant potassium-sparing diuretics such as triamterene or spironolactone. In your heart failure patients, which we'll get to in the second part of the lecture, you'll often see people on spironolactone and ACE inhibitors. So you're going to want to make sure that you're monitoring their potassium. ACE inhibitors patients on ACE inhibitors can also sometimes present with a dry cough. And this is due to the increased bradykinin. This is something that can be bothersome to patients. It's not detrimental, like it's not going to hurt them, but it's just kind of annoying and bothersome. So for that reason, you can change the agent from an ACE inhibitor to an ARB. An ARB, as we'll talk about, doesn't affect bradykinin, so you're not going to see that dry cough that you can see with ACE inhibitors. Angioedema is another side effect that patients on ACE inhibitors can present with. It can occur at any time during the course of the therapy, so even if a patient has been on an ACE inhibitor for years, they can develop angioedema due to the drug. ARBs can be considered as a substitute if benefit outweighs the risk. So if you really need someone because of comorbidities to be on on an angiotensin inhibitor of such, then an ARB can be considered because angioedema is reported infrequently with ARBs. However, it does still sometimes occur, but it's pretty infrequent. Also, ACE inhibitors are contraindicated in bilateral renal artery stenosis. So you're going to want to avoid ACE inhibitors in those patients because it can reduce the GFR and cause renal failure. Angiotensin receptor blockers, or ARBs, have very similar effects to ACE inhibitors. So with these drugs, there's antagonism at the type 1 angiotensin 2 receptor. So you're also inhibiting angiotensin 2 versus inhibiting the angiotensin converting enzyme. So the net effect is still a decrease in angiotensin 2 with an ACE inhibitor and an ARB. However, ARBs do not have any effect on bradykinin. So this is why there's less risk of dry cough and angioedema compared to ACE inhibitors. ARBs can also have benefits in patients that have heart failure, and they're also contraindicated in patients with bilateral renal artery stenosis. And it's important to note also that both ACEs and ARBs are contraindicated in pregnancy. Calcium channel blockers decrease blood pressure by inhibiting calcium influx into arterial smooth muscle cells. So they cause smooth muscle cell relaxation or vasodilation. They decrease myocardial contractile force, and they can decrease heart rate. So calcium channel blockers, in addition to being used for hypertension, are also used to treat angina and arrhythmias. So there's two types of calcium channel blockers, the dihydropyridines and the non-dihydropyridines, which I'll talk about on the next slide. So the dihydropyridines, you can recognize these in that they all end with pine at the end of the drug name. So amlodipine, although you don't pronounce them as pine. So they're pronounced amlodipine, felodipine, nifedipine, nicardipine, isradipine. And these medications, the dihydropyridines, they're more smooth muscle selective. So these drugs are primarily used to treat hypertension versus the angina and arrhythmias. Because of their vasodilatation effects, they can cause reflex cardiac stimulation, which can increase myocardial oxygen demand. So this is important as well to note that they're not good things, or these are not the calcium channel blockers that you want to use for angina therapy or for heart rate control. Something also very important to point out is that you never ever use nifedipine immediate release for hypertension. You're probably not going to see immediate release nifedipine used. They're used in specific patient populations, like as a tocolytic for pregnant patients and in Raynaud's disease. But the reason why is because it's been reported that the rapid drop in blood pressure with reflex tachycardia has actually resulted in deaths. So you're never going to prescribe immediate release nifedipine for hypertension. So the non-dihydropyridine calcium channel blockers are used for some of those other indications. Verapamil, one of these non-dihydropyridine calcium channel blockers, is relatively selective for myocardium, and it's used for angina and arrhythmias, and it decreases myocardial oxygen demand. Diltiazem has intermediate selectivity for vascular calcium channel blockers, can cause vasodilation without producing the same degree of reflex tachycardia simulation as some of those dihydropyridines can. For monitoring for calcium channel blockers, of course, you're going to monitor for blood pressure response. In the dihydropyridines, they can cause flushing, headache, excessive hypotension, and reflex tachycardia, which we talked about, and as well as some patients will report edema with the dihydropyridines. In the non-dihydropyridines, excessive bradycardia, because it can affect heart rate, is an important side effect to be aware of. Also AV block and decreased contractility. So these drugs are drugs that you're going to want to avoid in your patients with heart failure that have systolic dysfunction, because of the decreased contractility might make their heart failure worse. So this table includes some other drugs that are used for the treatment of hypertension, but we won't cover them in depth in this lecture because these medications, the guidelines have now designated as later line alternatives for the treatment of hypertension. You may see some of your patients in your primary care practice on these medications for their hypertension historically, based on previous versions of the hypertensive treatment guidelines. But these agents are primarily going to be used in those patients that you'll refer to hypertensive specialists when the drugs, that the 4 classes of agents that you're using, are either ineffective or a patient has contraindication to them. So some of them that I want to point out on this slide are aldosterone antagonists, which we'll talk about in the heart failure section in the second part of this lecture. And spironolactone is also a potassium-sparing diuretic, so you might see it referred to as a potassium-sparing diuretic or an aldosterone antagonist. Alpha-1 blockers is a class of drugs, includes some other agents that aren't listed here, but these are ones that may be used to treat hypertension. The other drugs in this class are used to treat benign prostatic hypertrophy, and some of these agents can do that as well, and that's BPH. There's also beta blockers, which we'll talk about in the heart failure section. And some of these beta blockers also have alpha blocking activity. And you can further break down beta blockers into the selectivity that they have for the beta receptors, and their action on alpha receptors. So now we'll switch gears a little bit, and we're going to start talking about the pharmacotherapy of heart failure. And you'll see that we use the same drugs to treat hypertension for heart failure, but there's a different rationale for their use. So just to review, heart failure treatment goals are really to improve symptoms and quality of life of the patient, to slow the progression or reverse cardiac dysfunction, and then also, most importantly, is to reduce mortality. Treatment of heart failure is often based on the stage of heart failure that the patient is in. So this slide reviews the stages of heart failure as described by the American College of Cardiology Foundation and American Heart Association, compared to the functional classification put forth by the New York Heart Association. So you can review this table, but I just want to emphasize that the American Heart Association stages emphasize the development and progression of the disease, and the New York Heart Association classes focus on exercise capacity and symptomatic status of the disease, and kind of helps us picture these states better. Notice that stages A and B are patients who are at risk for heart failure, so focus will be primarily on prevention, whereas stages C and D have those patients actually have heart failure. This slide is a very simplified summary slide of treatment for heart failure by stage based on the 2013 American Heart Association update to the guidelines for the management of heart failure. So we'll go through this more in detail when we talk about the different agents in the subsequent slides, but this table kind of helps you think about everything just in a summarized view and put everything together. ACE inhibitors are used in heart failure because they decrease mortality in heart failure patients. Numerous large-scale studies have validated this reduced risk of hospitalization and death in patients that are on ACE inhibitors. So as I talked about before in the hypertension part of the lecture, ACE inhibitors inhibit angiotensin II, which decrease blood volume, slow cardiac remodeling, and reduces preload and afterload, which is advantageous for heart failure patients. So this slide is from the American Heart Failure Society of America's 2010 practice guidelines and talks about the role of ACE inhibitors in treatment of heart failure. So ACE inhibitors are recommended for symptomatic and asymptomatic patients with a left ventricular ejection fraction less than or equal to 40%. Strength of evidence is A, which is the highest strength of evidence. ACE inhibitors should be also titrated up to doses that are used in clinical trials. So your initial dose that you start them on might not be the dose that they end up on, and you should really try to get them to the doses that are used in these clinical trials. But you have to sometimes do it slower and make sure that the patient is tolerating it, because you also may be titrating them up on a beta blocker as well, and there can be some adverse effects from that. So you want to make sure that the patient is tolerating it as you work them towards these doses that are used in the trials that have shown benefit and reduced mortality in patients. And ACE inhibitors are also recommended as routine therapy for asymptomatic patients with a left with an LVEF less than or equal to 40, in patients with a stronger level of evidence for patients especially who've had a previous MI. If a patient is unable to tolerate an ACE inhibitor due to the dry, annoying cough that we talked about before, then ARBs are recommended as a substitute. If patients cannot tolerate an ARB, then the guidelines recommend the combination of hydralazine and an oral nitrate to be used as a substitute. For patients that are intolerant to ACE inhibitors because of hyperkalemia or renal insufficiency, they are likely to experience the same side effect with ARBs. So in that case, they should be tried on hydralazine and an oral nitrate as a substitute to the ACE inhibitor. So as I mentioned in a previous slide, not all beta blockers are created equal. So beta blockers vary based on how they interact with the various beta receptors in the body. And then also there's some beta blockers that have affinity for alpha receptors as well. But the main antihypertensive action of beta blockers comes from the antagonism of the beta-1 receptor. So beta blockers will block catecholamine interaction with this receptor, and they can decrease heart rate and contractility. So the beta-1 selective beta blockers are atenolol, bisoprolol, metoprolol, and nebivolol. So beta blockers are useful in heart failure because they inhibit the adverse effects of the sympathetic nervous system. So the sympathetic nervous system can impair sodium excretion from the kidneys, which causes water retention, which is not good for patients with heart failure. And the sympathetic nervous system can also cause vasoconstriction, which increases ventricular volume and pressures, which is not good for heart failure patients as well. The sympathetic nervous system can also cause arrhythmias, so also bad news for heart failure patients. So that's how beta blockers are beneficial to patients with heart failure. Now, again, further emphasizing that not all beta blockers are created equal, that there are 3 beta blockers specifically that have been shown to decrease mortality in heart failure randomized controlled trials. So these are the 3 beta blockers that should specifically be used in your heart failure patients to decrease mortality. And those are carvedilol, which has beta and alpha blocking, bisoprolol, or specifically extended release metoprolol. So not immediate release, this is the extended release that has been shown in trials. So this is the form of metoprolol that you'd want to use. So in our heart failure patients that are on beta blockers, we want to make sure that we're monitoring blood pressure because, of course, they can cause hypotension and they can also cause bradycardia. Postural hypotension is something also to be concerned with beta blockers because dizziness, especially in your elderly patients, if they're dizzy and they have falls, this is especially detrimental in this population. Beta blockers can also cause fatigue, and it's not a reason to discontinue the beta blocker, but it should be something that you cover in your counseling to patients when you're starting them on the beta blocker. If patients do report that they do feel fatigued after starting the beta blocker, you might need to reduce the dose and then titrate up more slowly. Beta blockers should really be avoided in patients with uncontrolled asthma and also patients that have reactive airway. However, you can use in stable asthma patients and stable COPD patients, and you might want to choose a beta-1 selective agent specifically then. Also, beta blockers can block signs and symptoms of hypoglycemia in diabetic patients. And so, again, this is not a contraindication for therapy in your heart failure patients, but you just want to make sure to counsel your patients and let them know that when they do become hypoglycemic, they might not have the same signs and symptoms that they're used to seeing. So this slide summarizes the recommendations from the Heart Failure Society of America for beta blockers, noting that beta blockers are shown to be effective and they're recommended for symptomatic and asymptomatic patients with an LVEF that's less than or equal to 40, and they're recommended as routine therapy for asymptomatic patients with reduced left ventricular ejection fraction with greater strength of evidence in patients that have had an MI. And this slide kind of reinforces some of the things that I talked about in the introductory slide to beta blockers, that even if a patient has concomitant diabetes or COPD or peripheral vascular disease, that beta blocker is recommended in these patients, in the great majority of these patients. Again, using caution in patients who have limb ischemia, but also the patients who have hypoglycemia or history of hypoglycemia that are diabetic. Use considerable caution in patients with marked bradycardia or marked hypotension. As I said, beta blockers can cause hypotension and bradycardia. And then also patients with uncontrolled active bronchospasm, uncontrolled asthma, that beta blockers are not recommended for these patients. Loop diuretics are the preferred diuretic to help decrease volume overload and symptoms of congestion and heart failure. So it is important to note that as opposed to some of the other medication classes that we talked about that actually decrease mortality in patients with heart failure, loop diuretics improve symptoms but do not have any mortality benefit. They do this by inhibiting reabsorption of sodium and chloride in the ascending loop of Henle and distal renal tubule. This increases sodium excretion and enhances free water excretion. Loop diuretics they typically can maintain action until severe renal repairment. So in other words, they'll work until a patient is very, very renally compromised, and then they might tend to start losing effect. Also in patients where they might be refractory to the use of loop diuretics, sometimes they are combined with metolazone, which acts on the distal tubule. And it's important that when these drugs are administered together, to give the metolazone before the loop diuretic to make sure it has adequate delivery to the site of action so that you can get the best response. So again, the Heart Failure Society of America guidelines indicate that diuretic therapy is recommended to maintain normal volume status in patients that are fluid overloaded. Patients that have congestive symptoms, which can include orthopnea, edema, and shortness of breath, or have signs of elevated filling pressures, which include jugular venous distension, peripheral edema, and less commonly rales. Also indicating that loop diuretics rather than thiazide type diuretics are typically necessary in order to restore this normal volume status in patients with heart failure. Aldosterone antagonists such as spironolactone are the only diuretics that decrease mortality for patients with heart failure. Sometimes these agents are also called potassium-sparing diuretics, but when they're used to treat heart failure, we call them aldosterone antagonists because of the important function that they serve in helping to decrease or slow the progression of clinical heart failure. Aldosterone promotes sodium and water retention and potassium secretion. So blocking aldosterone helps decrease renal hypoperfusion. And hypoperfusion is bad because it can promote a neurohormonal response or a hyperaldosterone state that results in myocardial remodeling, leading to clinical heart failure. So aldosterone agonists are recommended in patients with New York Heart Association class 2 to 4 with left ventricular ejection fractions less than or equal to 35%. For patients that have class 2 heart failure, they should have, these agents are indicated if they have a history of prior cardiovascular hospitalization or elevated plasma natriuretic peptide levels. So it's important to monitor potassium in your patients that are on aldosterone antagonists. As I had mentioned, these are potassium-sparing diuretics, so you should not use them in patients that have elevated potassium to begin with, greater than 5. And then also a lot of patients with heart failure that are on loop diuretics to help with volume overload, because loop diuretics waste potassium. A lot of them are on potassium supplements. So if you're starting an aldosterone antagonist, make sure to reduce or discontinue potassium supplements if the patient is on those as well, so that the potassium level doesn't creep up on you. If your patient has some impaired renal function with an estimated creatinine clearance of less than 30, this also can increase your risk of hyperkalemia. The guidelines recommend to monitor potassium and serum creatinine 3 days after starting the aldosterone antagonist, and then in 1 week, and then monthly times 3 months. It's important to titrate the dose slowly in order to decrease that risk of hyperkalemia, and also to note that when patients are on high doses of ACE inhibitors, the risk of hyperkalemia is also elevated. The guidelines specifically recommend against a routine use of ACE inhibitor plus an ARB plus an aldosterone antagonist, because it can be potentially harmful with the risk of hypotension and hyperkalemia. Digoxin is a very old drug that comes from the plant commonly known as foxglove, and its clinical effects date back to 1785 by William Withering, who was an English botanist and physician. It's a very pretty plant, and if you're interested in seeing some and you're ever on Concordia's campus, if you come over by the pharmacy building, there's some plants that are landscaped around the big mortar and pestle outside the front doors to the building. And those plants there, some of which are medicinal plants, you can see some foxglove. So digoxin is used in heart failure patients because it is a positive inotrope, which means that it increases the strength of the heart muscle contraction. This also decreases cardiac oxygen demand and can increase cardiac output. It has a limited role in heart failure, though it can be beneficial in patients that are already on optimal therapy to help decrease hospitalizations, but it has not been shown to decrease overall mortality in heart failure patients. There is some data out there that if digoxin levels increase to greater than 1.5, it can actually increase patients' risk of mortality. So when you're starting your patient on digoxin, or thinking about starting your patient on digoxin, you really need to weigh the benefits versus risks. So some guidelines when you're using digoxin therapy in your patients. You want to make sure that you use a low dose, especially in the elderly or patients that are renally impaired or have low body weight. And that's because these patients have a decreased excretion of the drug. And as I said, you don't want those digoxin levels to be elevated in your patients. A starting dose might be 0.125 milligrams daily or even every other day. And there is no reason in heart failure to use a loading dose, although you may see loading doses used of digoxin used in the treatment of atrial fibrillation. It's not necessary in patients with heart failure. Also, the general therapeutic range of digoxin levels is 0.8 to 2. However, in heart failure, you want to make sure that these levels are lower, so anywhere between 0.5 and 0.9. So you want them less than 1. This differs from AFib, where you might want higher levels, but again, higher levels in heart failure is associated with increased mortality, so we want to make sure that our levels are less than 1. Something to counsel your patients on and also to be aware of, signs and symptoms of digoxin toxicity are typically seen when levels are greater than 3. You might see patients with mental status changes, with nausea and vomiting, with visual disturbances. Sometimes patients describe this as people having halos on their heads. Also, patients may present with bradycardia or arrhythmias. I also want to point out a consideration for your African American patients with heart failure. The African American heart failure trial looked at patients that were African American and had left ventricular systolic dysfunction. And they noted that outcomes improved when the use of isosorbide dinitrate and hydralazine in combination was used as adjunctive therapy. They saw a 43% mortality benefit and a 33% reduction in hospitalization for heart failure. So this has been incorporated into the guidelines for African American patients, that in addition to beta blockers and ACE inhibitors as standard of therapy, African Americans with heart failure and reduced left ventricular ejection fraction should also be started on a combination of hydralazine and isosorbate dinitrate. This concludes the pharmacotherapy of hypertension and heart failure lecture, and please be sure to post any questions that you might have on the Ask the Pharmacist discussion board. Thanks.